Hello, I'm Donn Colby, Senior Research Physician at the Henry Jackson Foundation and the U.S. Military HIV Research Program. Today, I'm going to give a presentation on an update on STI prevention and treatment. During 2021, we had a lot of news on STIs, so there's a lot to cover today. These are my disclosures and disclaimer. Let's start with a little bit of epidemiology. Worldwide STI incidence for the latest year that we have data, 2020. In terms of some of the other STIs that we don't necessarily always think about as STIs, like HIV, hepatitis B, hepatitis C, worldwide, there's about 1.5 new infections of each one of those diseases every year. But let's see for the other more traditional STIs, how many there are. So syphilis, over 7 million new infections per year. Gonorrhea, 82 million new infections. Chlamydia, 128 million new infections. And Trichomoniasis, 156 million. So we can see for STIs, many more new cases every year than there are for other viral diseases like HIV or hepatitis B or C. But we know that hepatitis B, hepatitis C, and HIV have much higher rates of mortality in the hundreds of thousands. Most STIs are treatable or curable, so much less of a issue with mortality, although they do have a high impact in terms of morbidity. But that does not mean that there is not mortality from STIs. So congenital syphilis, as we know, syphilis is rising throughout the world. As we see more syphilis in heterosexuals, we also see more congenital syphilis cases from mother to child transmission. And the estimate is about 200,000 deaths per year from congenital syphilis. The other STI that we see impact mortality is cervical cancer. Of course, cervical cancer is caused by HPV, which is a vaccine-preventable STI, and we'll have more about that later. In the Asia-Pacific, there's a very high burden of STIs. In fact, the Asia-Pacific has the highest number of STIs of any region in the world, which is not surprising because the Asia-Pacific also has the highest population in the world. Syphilis, there's about 1.5 million new infections per year in the region. And then gonorrhea, chlamydia, and trichomoniasis all have in the range of 40 to 50 million new infections per year just in this region. So in terms of disease burden and impact on individuals and healthcare systems, it's very high in the region. So before we get into issues of diagnosis and treatment, we got to start with the basics. And the basics is determining who's at risk and who we're going to screen for HIVs, for STIs. So we know that the CDC came out with new guidelines for STI treatment, and we'll go over those shortly. But concurrently with the new guidelines on treatment, the CDC published new guidelines for taking a sexual history. So this is very important because if we're going to do screening or testing or prevention, we have to know who's at risk. And pretty much any survey of primary care providers or patients finds out that in most medical settings, patients are not asked about their sexual practices or their sexual risks. So the guidelines from the CDC use the 5 Ps as a sort of a prompt for what should you do when you're taking a sexual history. So the 5 Ps are partners, who are their partners, what gender are they, practices, what kind of sex are people having, is it oral sex, penile vaginal sex, anal sex, protection from STIs, what are people doing, are they using condoms or not, are people on PrEP. Past history of STIs helps to know who may be at risk for STIs in the future. And then pregnancy intention is important as well in terms of condom use or other use for contraceptives. So these guidelines are available from the CDC on the CDC website, and go into this in much more detail than we can go into right now. So sticking with the P's for the next few slides, how about PEP and PrEP for STIs? So we all know about PEP and PrEP for HIV because we talk a lot about that, and we've been working on that for a long time. But we also have prophylaxis for STIs as well. There's been a couple of studies in the recent past that give us a little bit of data on this. So in terms of PrEP, there was one very small study with 30 MSM that were randomized to either doxycycline, 100 milligrams per day, or control. Control, basically, they just didn't take anything at all. And, in this small group, in a small study, that they found a 73% reduction in incidence of combined STIs with syphilis, gonorrhea, and chlamydia in the prophylaxis group. Post-exposure prophylaxis has also been recently evaluated, also using doxycycline. And this is a 200 milligram dose that was given once as a single dose at 24 to 72 hours after condomless anal sex, and can be taken up to 3 times per week. So this was done in a group of MSM that was a subgroup of the IPERGAY study. And the IPERGAY study, you may remember, is a study that gave us event-driven PrEP that was done in France and Canada. So this was in the same group, and what they found was also a 70 to 73% decrease in syphilis or chlamydia incidence, but they didn't find any change in gonorrhea incidence either. So these are 2 studies. Neither one is very big, not enough to change recommendations or guidelines at this point. But what I can say is that there are a number of ongoing trials now to look at this. Mostly using doxycycline for either PEP or PrEP or some combination. So I expect that over the next few years, as we get results of these studies, we'll be hearing a lot more about this. And maybe in the future, we will have a recommendation on using PEP or PrEP for STIs. Pre-exposure, we also have vaccination as a way to prevent STIs. So we have vaccines for hepatitis A and hepatitis B. Those are sexually transmitted infections, but we're not going to talk too much about those in this presentation. But we can talk a little bit more about the HPV vaccine. So HPV is a sexually transmitted disease. We have a vaccine for it. In fact, we have 4 vaccines that have been approved and are available in the market. And they differ in terms of like how many HPV types they protect against. So all of them protect against the 2 most common oncogenic strains, which are HPV 16 and 18. These are the strains that most likely or most frequently cause cervical cancer, or can cause anal cancer as well. So the US CDC indications for the HPV vaccine are males and females 9 to 26 years old. Ideally, the vaccine would be given before people become sexually active, because once you become sexually active, there's a high risk for being exposed to HPV because HPV is so common. In the new guidelines, they also add a indication for males and females from 27 to 45 years old. And this is based on what they call shared clinical decision-making, or discussion between the provider and the patient about their risk for HPV infection if they're not adequately vaccinated. And since these vaccines are relatively new, many people in the older age group never had the chance to be vaccinated because when they were 9 to 26 years old, the vaccines did not exist. So that's something we can think about on our older patients. And I know in my practice, I have given the HPV vaccine, mainly to MSM who are older, maybe in their 30s or 40s, and still had ongoing risk behavior. So that is an option for our older patients. On the topic of HPV, I want to announce that there has been some results announced from the ANCHOR study. So the ANCHOR study is a large study that was conducted in the USA, almost 4,500 people living with HIV who had HPV infection and had precancerous anal lesions known as HSIL, which is high-grade squamous intraepithelial lesions. And this included males, females, and transgenders, so all genders. And participants were randomized either to treatment of these precancerous lesions, which means to destroy the lesion in some way, and there's a couple different ways they can do that, or observation, where they didn't treat them at all, but had them come back every 6 months and continue to screen for transition to cancerous lesions. And this study was actually stopped early in October 2021 by the DSMB because the treatment significantly reduced the risk for progression to anal cancer. Now, they haven't released any other results of this study yet, so how much was the reduction? How many people actually went on to develop cancerous lesions? They haven't given us any of that data yet, but I expect that will be coming out sometime in 2022. And still going on the P's, don't forget partners. So, of course, a sexually transmitted infection was transmitted from somebody to your patient. So anytime you have a patient with STI, that means there's at least one other person out there somewhere who has the STI that they got it from. So the best thing is to encourage your patients to inform their sexual partners, that they have an STI, what it was, and then that their sexual partner should also come in and be seen, by you or anywhere else. Just get screened and treated for their STIs. One thing you can do is say if you're going to bring your patient back at some point in the future, say bring your partners with you, and we can treat at that time. There has been some evidence that if you give your patient some written information about the STI that they can show their partners, that actually improves referral rates. But if there's situations where it's difficult for the partner to come in, or for the patient to refer the partner, you can do something that's called expedited partner treatment, or EPT. And what that means is that you actually give an extra treatment course to the patient for them to give the partner. And treatment course means you actually give them the medicine itself, not a prescription, because they found that if you give a prescription, sometimes people fill it, sometimes they don't, but actually giving the medicine for the patient to give their partner increases the rate of actual treatment being received by the partner. So there's very good evidence that this works for chlamydia in heterosexual couples, in that it increases the success rate for partner treatment, and also decreases the rate of recurrence of the STI in the primary patient. And the recommendation is to treat all sexual partners within the past 60 days, or if they had no partners within the 60 days, to treat the most recent partner. Now, there's less clear evidence for other STIs, like gonorrhea or syphilis, mainly because those we usually treat with injections rather than pills, and it's harder to do that as through a patient. Also, less clear evidence for MSM. MSM have higher rates of STIs, often have multiple STIs, and a higher risk for HIV, which we may screen for when we're screening for other STIs. So it's not recommended for MSM as well. Just one note on STI testing. The new standard for collection of STI specimens for testing is self-collection. So in the old way, we would have the provider or a nurse, swab whatever orifice we're interested in, and then send that off to the lab. But there's a lot of evidence that if patients collect samples themselves, that the sensitivity and the specificity of the testing is comparable. Much higher patient satisfaction when patients can do it themselves. And there's also better staff satisfaction as well, because there's less work for the staff and less intensive as well. This can be done from any site that we collect specimens from. On the sites, you may notice that we did not put urethra there. And for the male urethra, now we tend not to swab those, because most of our newer testing in terms of NAT testing can be done on urine. So we don't necessarily need to swab the urethra. And it works for pretty much any STI that affects the genital tract, the mouth, or the anus as well. So you might ask, well, how do you do that? How do you give them instructions? There's actually a lot of patient materials in terms of posters or handouts that give very clear instructions for patients on how to collect the specimen and what to do to the specimen. And there's some links to where these posters and materials can be found and downloaded. Okay, so now we're going to get to the new CDC guidelines that came out in mid-2021. The previous STI guidelines from the CDC had come out in 2015. So there were 6 years between these guidelines, and there's actually been a lot of changes in the interim. The newer guidelines are much longer, about 30% longer in terms of number of pages, and there's a lot of new sections as well. So I won't have time to go through every single change in the guidelines, but we will be able to hit the highlights in the rest of the presentation. So first, just a note on the nomenclature of the guidelines. Previous guidelines were called STD, or Sexually Transmitted Disease Guidelines, and CDC is catching up with most of the rest of the world, which uses the terminology of sexually transmitted infection. The main difference is that disease refers to a disease state, meaning symptomatic, where STI or infection refers to the pathogen, which may be symptomatic or asymptomatic as well. Some people think that may be less stigmatizing as well. So the push now is to use the term STI over STD. So one notable change in the new guidelines is a new section on STI screening for transgender persons. In the 2015 guidelines, there was a small section that was about half a page that just basically said transgender people get STIs and they should be screened, but no specific screening recommendations. Whereas the newer guidelines have a much expanded section with very specific recommendations. For all transgendered persons, they recommend that the STI screening history examination be based on the patient's sexual practices and the gender of their sexual partners. So HIV screening is recommended for all transgender persons on a regular basis. And transgender persons with HIV are recommended to be screened annually for STIs. They do know that transgender persons who have sex with cis men are at similar risk for STIs as MSM, and we know MSM have a very high risk for STIs. So that means that transgenders that are having sex with men also have a very high risk for STIs. In terms of transgender women who have had vaginoplasty, they recommend routine STI screening at all exposed sites. In terms of the neovagina and doing STI testing, there's no data so far on whether we should do urine test versus a vaginal swab collection. So really either one of those is fine at this time because no evidence that one is better than the other. The neovaginal surgery does not create a cervix, so transgender women do not have a cervix and do not need cervical cancer screening. Now, for transgender men who have had surgery, if the vagina is still present, the recommendation is to use swabs over urine for bacterial STIs because that surgery actually changes the location of the urethra and it may be less susceptible to STI. So really swabs are better than urine. And for a transgender man that retain their cervix, they should have cervical cancer screening per current guidelines for cis women. There's been a few changes in recommended treatment for STIs in the new guidelines. First, for chlamydia, on the old guidelines, the recommendation was azithromycin as the first regimen as a single dose, and doxycycline as an alternative, and then several other alternatives as well. The new recommendation is not to use azithromycin as a first line, but to use doxycycline, 100 milligrams twice a day, with azithromycin reserved as a alternative regimen. So why this change? And it's basically based on evidence that doxycycline is more effective than azithromycin. So doxycycline is very efficacious at all anatomic sites where people can get chlamydia, and they have noted over the last few years higher rates of failure of treatment in males, not so much in females, but definitely in males. And then a study that came out in 2021 that showed that the doxycycline was much more effective for rectal infection in males with 100% cure with doxycycline versus only 74% with azithromycin. So the recommendation now is the first-line treatment is doxycycline. There's still some situations when azithromycin may be appropriate. For example, pregnant women in whom doxycycline is contraindicated, or if people have an allergy intolerance to doxycycline, or if you have a patient who you just think is not going to take medicine for 7 days and can take a one pill that you might even do as directly observed. So gonorrhea treatment also has new recommendations. The previous recommendation was to use a shot of ceftriaxone, 250 milligrams, plus a single oral dose of azithromycin. So one question I'd like you to answer, at least in your head, you don't need to say it out loud, is what was the rationale for adding azithromycin to ceftriaxone in the 2015 guidelines? And my guess is that most people misunderstand why that was the case. And 2 slides from now, I'll explain to you what the reason was for azithromycin to be in the previous guidelines and why it has been taken out of the current guidelines. So the new recommendation is to use ceftriaxone alone without azithromycin and at a higher dose, 500 milligrams as a single IM injection. And then there's some alternative regimens as well. So this is for genital infection or rectal infection. There's a alternative guideline for oropharyngeal infection, and again, that has changed from ceftriaxone plus azithromycin to a single dose of ceftriaxone, 500 milligrams as well. There's no alternative regimens recommended, basically because there's no evidence that any other regimen is efficacious for treating oropharyngeal gonorrhea. So why the change? So the change is to prevent antimicrobial resistance. So the question I asked 2 slides ago was, in the 2015 guidelines, why was azithromycin added to ceftriaxone? I think most people think that the reason it was there was because if people have gonorrhea, they might have chlamydia as well, and we want to treat both at the same time. And that's, I think that's a reasonable thing to assume, but that's actually not correct. So if you read the 2015 guidelines carefully, it explains in there that the reason azithromycin was added was to prevent gonorrhea resistance to ceftriaxone from developing. So going back 7-8 years ago, when those previous guidelines were written, there was a big concern that gonorrhea might become resistant to ceftriaxone. And if that happened, we'd sort of run out of ways to treat gonorrhea. So azithromycin was added to the regimen as a second agent with a different mechanism of action to prevent resistance to ceftriaxone. Now, as time has gone on, there's still a concern about resistance developing, but it hasn't developed, as to the degree or as quickly as people were worried about in the past. But over the last few years, there's been emergent resistance to azithromycin in other organisms. For example, strep pneumonia and Mycoplasma genitalium have increasing rates of resistance to azithromycin based on use of azithromycin and exposure to it as well. So the idea is to use azithromycin less in the future so that other organisms do not develop resistance to the same degree. And it turns out that the higher dose of ceftriaxone, 500 milligrams versus 250 milligrams, is also very effective at preventing resistance. So that's why the change was implemented. There's also been some change in treatment of non-gonococcal urethritis, or NGU, and that's basically also changing from azithromycin to doxycycline, again for the reasons of preventing emerging resistance to azithromycin, and because doxycycline is very effective treatment in this case. Something else new in the guidelines is a new section on Mycoplasma genitalium. So in the previous guidelines, there was a little bit about M. genitalium, but it was incorporated into the section on NGU. But in the new guidelines, Mycoplasma has a section all to itself. So in terms of the epidemiology, we know that the symptomatic infections can be seen in both males and females. In males, there are a fairly high percent of the cases of NGU. The actual etiology is Mycoplasma genitalium, and then that's even higher in persistent or recurrent urethritis. For females, we know that infection with Mycoplasma genitalium is associated with infertility, cervicitis, PID, and for pregnant women, can lead to preterm delivery or spontaneous abortion. Now, we have a lot less data on asymptomatic infection and the significance of that in either males or females. So there's no recommendation now to either screen for asymptomatic infection or to treat it if it was found. In terms of diagnosis, Mycoplasma is similar to chlamydia in that very, very difficult to culture in conventional laboratories. So that's just not available to us. But there is a diagnosis through NAT or PCR testing, which can be done on urine or on genital swabs. Now, there is high rates of macrolide resistance found in Western countries, up to 90% in some places. So that affects our treatment regimens, but it also, because it's important, they're starting to incorporate the genotypic resistance testing into the NAT diagnostics that should be available in the future. I don't think those are available yet, but it's something similar to the Gene Expert in TB, where when you send a test for Mycoplasma, you get a result which is positive or negative for presence of the bacteria, but it'll also give you a genotype test to tell if the Mycoplasma is resistant to macrolides, mainly azithromycin. So because of that, the expectation that we'll have that genotypic resistance testing available in the future, the CDC guidelines incorporate that into the guidelines, even though most people probably don't have it available to them yet. But anyway, in the old guidelines, there was no specific treatment recommendations for Mycoplasma, but the new guidelines have a recommendation based on if there's macrolide sensitivity or not. But either way, you start out with doxycycline for 7 days, and then if there's macrolide sensitivity, then add azithromycin, or if resistant to macrolides, then the second drug is moxifloxacin. And if you're in a situation where you just don't have the resistance testing available, which is probably most people currently today, then the treatment recommendation is doxycycline followed by moxifloxacin. PID treatment has some changes, mainly the addition of metronidazole to the other regimens, or clindamycin as an alternative. And the reason for that is not that the regimen is any more effective at treating acute infections, but to prevent long-term sequelae such as infertility or ectopic pregnancy. At both regimens, the old ones and new ones, are equal in terms of treating standard STIs like gonorrhea or chlamydia, but the addition of metronidazole results in higher clearance of anaerobic microbes from the upper genital tract. And the thought is that that will prevent longer-term sequelae, such as infertility or ectopic pregnancy. And then finally, the last treatment change we're going to talk about is trichomoniasis. That has changes in both the diagnosis and treatment. So in the old days, the diagnosis was primarily by wet mount microscopy, just visually looking at it and seeing it under the microscope. But now we have available newer tests using NAT technology, which are much more sensitive for detecting infection. The treatment has also changed. In the past, the treatment recommendation for men and women was the same, mainly a single dose of metronidazole, 2 grams orally, or tinidazole as an alternative. The newer recommendations in the guidelines now recommend an extended regimen of 7 days for women. That's because there's been new evidence that the extended regimen results in better rates of clearance and lower rates of recurrence. For men, the recommendation is still the 2 grams orally as a single dose. And that hasn't changed, basically because there's no new evidence for men. Doesn't mean that the 2 grams is any better than 7 days for men, just that we don't have any new evidence for men that 7 days is any better than 2 grams. So they left the recommendation for 2 grams as a single dose. So that concludes the lecture. Thanks for listening and hope you have a good day. Bye.